am excited to introduce Ethan Weinberg. Ethan comes to us from University of Pennsylvania. Again, he is the epitome of an excellent hepatologist. He's come to our conference before, and again, his talks are always highly acclaimed, and it's really, he's transparent, he's thoughtful. Patients love him. He explains things well. So we wanted him to come back, and in fact, we asked him to do the non-invasive testing for AIH patients. So I know many of you got your fibrin scans done this morning. If you have them, you can pull out your sheet, and Dr. Weinberg will talk about it. He'll also talk about, I think, a few other strategies, too, in terms of non-invasive testing as well. So if you will join me in welcoming Dr. Weinberg back to the AIHA.
Thanks, Craig. I'm excited to be here. When Craig asked me to speak again in the spring, I said, of course, if you want me to come out. I had a great time. I was here in 2019, the last time we were in person, and I get to speak to doctors a lot, but I don't get to speak to large groups of patients, and I find that it's actually more fun to speak to large groups of patients and caregivers than it is to doctors. I'm less nervous. I feel more comfortable. You can shout out questions while I speak. I don't mind, okay? So I'm going to be talking about non-invasive testing for patients with autoimmune hepatitis, but in general for liver disease and how it relates to autoimmune hepatitis. So what invasive tests do we use in autoimmune hepatitis? So I would say there are three that really came to mind. There's the percutaneous liver biopsy, and that's the one where either a radiologist or a hepatologist will perform a liver biopsy through the right side to the liver. The interventional radiologist will do a transjugular liver biopsy, that's through the neck. And then you may have an upper endoscopy to check for signs of portal hypertension or varices. And why do we do these tests? So for the liver biopsy, the percutaneous liver biopsy, what we're looking at is we want to be able to look at the liver under the microscope. And there's actually a talk tomorrow by one of the Indiana University pathologists, which will be fascinating to see. And what we're looking at is the inflammation and sort of disease activity in the fibrosis. When we do a transjugular liver biopsy, what we're looking for is that inflammation and activity and scar tissue, fibrosis again, but also the pressure in the liver. And then when we do an upper endoscopy, we're looking for signs of portal hypertension, high pressure in the liver, and whether there are varices, those large veins. So what are the drawbacks of invasive tests? So some of these I thought of my own, and some of them my wife thought of. So what are the drawbacks? Why, if you say, why would you want an invasive test? Why would you want a non-invasive test? Because there are injuries. I perform liver biopsies, and even though I've done dozens or hundreds, they still make me nervous because there's that risk of injury. About 1 in 500 can have severe bleeding from a biopsy. The liver is highly vascularized, and even with using an ultrasound to try to find the right location, there's still a risk of bleeding. They're expensive. A blood test can be $10. A procedure can cost thousands. They're time consuming. You have to take a day off of work to have an endoscopy or a biopsy. You get sedation. There's anxiety associated with it, the sort of dread of having to go to an invasive test. They're uncomfortable. Nobody comes back, nobody tells me that a liver biopsy was a great experience. I've never heard that sentence ever. My wife said they're gross. You just don't want to think about invasive tests. They're inconvenient. I perform my procedures on a Thursday. What if Thursday's your day at work when you have meetings? This doesn't work well. You can get a blood test any day of the week. Parking. So I practice at the University of Pennsylvania, and my patients complain to me that parking is the absolute worst thing of anything they do. They don't want to see me. I actually now I see patients now at one of our outreach clinics, and people are clamoring to go to the outreach clinics because you park right there and you walk right in. But the parking for just to have an invasive procedure at our large hospital, I don't think you have that here. The parking seems great here. Is that right, Craig? No, it's awful. All right. So parking, and then time off of work. So, if I'm just thinking about myself. If I needed a procedure, I'd say, I have to look at my calendar. When do I have to take time off of work for this? So non-invasive tests are great. So they don't have any of these sort of aspects. So what are the types of non-invasive tests that we're looking at? So I have 5 different categories. The first ones, we're sort of looking at inflammation and disease activity. And then we're looking at fibrosis. Scar tissue is another way of saying fibrosis. Then we're looking at portal hypertension. And we'll also do cancer screening as a non-invasive test. And then sort of the future of hepatology is we can do non-invasive tests to actually look at how your liver is functioning. So that's where the little star there. Some of the tests are not FDA approved yet. So inflammation and disease activity. So here we go. This is what we might see at a diagnosis biopsy for autoimmune hepatitis. Hopefully this isn't what we're seeing with ongoing therapy, although sometimes we do. But what we're seeing, there's a few different things that we see with acute inflammation and disease activity, and this is just some medical jargon. Periportal necrosis, intralobular necrosis, portal inflammation. These are sort of words you might see on a pathology report. And then the things that we look for chronically are fibrosis. In general, so this on the right side, this is sort of what the liver looks like on the healthy side, and this is what we call interface hepatitis. So there's a lot of this, there's a lot of lymphocytes, white blood cells that are sort of invading into the healthy part of the liver. So what are the blood tests we do for immune activity, or for activity? So you are probably very familiar with the ALT, the AST, and the GGT. So, and these are enzymes that are inside our liver cells. Particularly the ALT and the AST are more, particularly the ALT is really just seen in these hepatocytes. This is a cartoon of hepatocytes. That's the main liver cell. There are also other cells in the liver. There are also other cells in the liver. The GGT can be is an enzyme that's seen both in hepatocytes and cholangiocytes. And so if you have, there are other autoimmune liver diseases that can raise the GGT, but these are markers that your clinician will check regularly to see whether you have increased or decreased immune activity or disease activity. But they're okay. They can sort of tell us, they're very cheap to do. I think, you can get your liver enzymes checked. It's probably $10 or something like that. And they can go up and down, but overall we want to see that they stay on the lower side. But if the ALT goes from 25 to 30 back to 25, it's okay. There will be some variation depending on your activity and what you ate. Also, time of day, these sorts of things. There can be just variability in the test too. So if the ALT goes up slightly and then comes back down, it's fine. It's really the trend that we want to look out for there. And then there's also markers of immune activity. So lymphocytes are predominant in autoimmune diseases. And what we check for is something called the immunoglobulin G. And here's a little cartoon on the right of immunoglobulin G. And this is the antibody that your body makes sort of long-term. So we have IgM and IgG is sort of one of the antibodies we make long-term. So these are, it comes to my first question. Do you regularly receive IgG testing with liver enzyme testing? So the reason I ask this is because I assumed all clinicians did this, but at my own institutions, a lot of my colleagues don't. So just checking to see what we have there. And I don't know if I know how to even, let's see. Do we have, oh, good. I'll wait a little bit and see. All right, so it actually looks about 50-50, and this is what I saw at my own institution. Craig and I actually worked on a paper together, looking, and I'll talk to you guys more about it tomorrow. But what we found, one of the things that the reviewers said that we didn't do was we didn't test IgG enough, and it wasn't that I didn't test IgG enough, but our people in our system don't test it. So it's important that as a clinician, I get the word out to my fellow clinicians that IgG is part of sort of non-invasive testing for autoimmune activity in autoimmune hepatitis. I didn't know that the multiscan people would be here, but I thought this was very cool. So this is a non-invasive test that may work. It's an MRI that can actually show some inflammation, and this is in development for inflammatory liver diseases. So this CT1 will tell you whether there's a lot of inflammation or not, and so they can use these really neat pictures to see whether there's inflammation throughout the liver. So stay tuned about that. It's not prime time yet. All right, next up is fibrosis. So these are the different stages of fibrosis. When your doctor talks about whether you have F2 or F3 or F4 or F0, what they're talking about is how much scar tissue is in the liver and this is what it corresponds to. It's not important that you know this. If these slides are available later, you guys can look over this later. But we give them a number, but it's really, this is what they look like on a histology slide. So F2 means there's a certain medical definition. F3, there's a medical definition. F4 is cirrhosis. So we have blood tests that correlate with how much fibrosis or scar tissue is in the liver. So there's some non-proprietary tests. There's what we call the APRI test, and that simply is looking at your AST and your platelet count, and there's a formula, and you put it in, it spits out a number, and then it says, okay, you are at risk for fibrosis, or you have a low risk of, you're a high risk fibrosis or low risk of fibrosis. There's also the FIB4, and this is actually used probably the most of these non-proprietary tests, and it uses two of the liver enzymes, age and platelet count. And what's great, and FIB4 works well, it works well for pretty much all liver diseases to tell us whether we should be concerned about advanced fibrosis or not. And it's much more of a screening test. If the FIB4 is elevated, then we'll look and do some imaging tests, which we'll talk about next. There's also FORNs. I haven't used FORNs, but it seems to be validated. There are some proprietary tests down at the bottom. The ELF test in particular is excellent, but I have not used it. I don't know that it's readily available in the United States outside of clinical trials. In the clinical trials I'm involved in, we typically will use the ELF test. There's also FibroTest and FibroSure, which uses a mix of proprietary and non-proprietary tests. I haven't found the FibroTest and FibroSure is really that much better than the FIB4. And so initially when I was practicing, I started using the FibroTest a lot, but it's fallen out of favor now that I have easy access to FibroScan. So next question. Has your provider ordered blood tests for fibrosis? And if yes, which ones? Okay, that's interesting. So it's actually, there aren't that many people in this room that have had a blood test for fibrosis ordered. So if you are interested and intrepid, you can do your own, you can actually do your own. So if you have your labs available, you know, on your LabCorp app or wherever you have your labs, you can actually do your own FIB4. There's a FIB4 calculator on MD Calc, and it can give you those things. You don't have to do it right now. I'm just saying, if your provider doesn't provide you with the FIB4, and that's what's great about the FIB4, it really is 4 tests. One of them, which is age, so you don't need to look on LabCorp app for that one. And then as long as you have a CBC and a hepatic function panel, which is usually what I order for my patients anytime I'm looking to see whether there's disease activity, you can calculate your own FIB4. I will say, because age is part of it, there is, at the age of 65 or above, we're less concerned about higher numbers because age is in the numerator. All right, so the next section we're talking about imaging tests for fibrosis. So there's 3 big ones. There's the FibroScan, which it sounds like many of you got here in the room today. There's also ultrasound elastography, so the standard abdominal ultrasound to look at your liver. We can also look at liver stiffness. And then there's MRI elastography, so we can look at liver stiffness through an MRI. And I've just put on a review from Elliot Tapper, just sort of looking at the pluses and minuses of these different tests. This was in patients with steatotic, this was for steatotic liver disease, but the same things hold true as far as cost and what the confounders are. So I know many of you got the FibroScan, and I'm actually I'm going to go over what the FibroScan results mean. At Penn, I perform my own FibroScans on patients, and I tell them the answers, not the answers, the results right away and what we're going to do. So you guys experience this. You have this little, the probe goes in between your ribs. It puts a sound wave through your liver, and then it looks to see how fast that sound waves moves through your liver. So the sort of the origin story of the FibroScan, I don't know if anyone talked to you guys about this, but there was a French liver doctor who saw how they looked at how they looked at whether cheese was ripe. So because if you want to know how hard the cheese is, you don't want to open it up. So they had this like very rudimentary sort of fiber scan to look to see how dense the cheese was, whether it aged enough. And then this guy had this great sort of eureka idea that the liver's sort of like cheese. Why don't we turn this into something we can use for patients? And the fiber scan itself has saved me probably thousands of liver biopsies, because whether for autoimmune hepatitis, I can, based on the non-invasive tests and fiber scan, I can tell whether I'm concerned about whether we need to change therapies using in combination. So with blood tests and fiber scan, I can make many decisions without having to do liver biopsy. Now, that's not to say that liver biopsy after diagnosis is not needed. I do them maybe once or twice a year to assess for surveillance in autoimmune hepatitis, but most of the time I can get away with fiber scan plus blood tests. And so I will usually do the fiber scan once a year or every other year to look at both disease activity and liver fat. So this is what the fiber scan will tell us. So it ranges, I don't think I had the CAP score in here, but there's two numbers you get on the fiber scan. So if you guys have your sheets out and you want to take a look at them, anything 6 or below is completely normal. And some people say, well, I was a 5 one day, I'm a 4 this year, and then I went back to a 5. I say, it's fine. Anything below 6 is normal. If you went from 5, 4 to 5, I'm not concerned about it at all. Between, I'd say, about 6 to 8, there's probably a mild amount of scar tissue. Maybe it's somewhere between F0 to F2, but it also depends on the CAP score, which we'll get into next. Between 8 and 12, we start to think that there's more fibrosis or scar tissue. 12 to 15 are really anywhere from up to about 15. I'm thinking maybe there may be cirrhosis. It's really early, and really this says above 12. It also depends on what the CAP score is, but if it's 12, sort of 12, 15 range or above, I get concerned about cirrhosis. And when it's 25 or above, or 20 above, depending on the platelet count, I start to think about whether portal hypertension is present. So I don't know if I don't have a slide on it. Sorry. I don't have a slide on the CAP score, but the CAP score tells us it's not nearly as precise as the KPA, as the liver stiffness score is. So the CAP score tells us relatively how much fat is in the liver. If the number is 215 or below, that tells me that you probably have no fat in the liver. If it's up to about 250, there's maybe some fat in the liver. Up to about 300, there's a fair amount of fat in the liver. And then over 300, that tells me that most of the liver is fat. So, when I say most of the liver is fat, there's fat droplets in the hepatocytes. So I'll usually look at that number and then also the liver stiffness, because as the CAP score goes up, it can elevate the liver stiffness. There are some tests, I actually didn't put in this talk, but there are some tests that combine FibroScan and liver enzymes, and they can tell you where disease activity is more for steatotic liver disease than autoimmune hepatitis. But these are conditions that can falsely elevate the liver stiffness. So acute hepatitis. So I don't perform a FibroScan around the time of diagnosis, because if one of my patients has an ALT of 500 or 600, it will be falsely elevated. So I usually wait and do it as something when looking at over time to follow to see how the disease activity is. Cholestasis, that means increased in alkaline phosphatase. It can be, if the BMI is elevated, it can increase the liver stiffness, as I said. If you have heart failure, if there's a clot in the portal vein, it can increase that. And then just breathing in and out. Sometimes that will change. When I'll do a FibroScan, I'll have a patient inhale and then exhale, and then I'll do the FibroScan on the exhale, because that can actually change. You can imagine as your lungs are bigger or smaller, that can change the pressure on your liver. So just breathing in and out, I can get different numbers in the FibroScan. What are the strengths? So it's fairly accurate. It's validated. One of the things that's not on the strengths is the fact that it's fast. So for places that have FibroScan, it's very fast. So I can see a patient look at labs, see how the symptoms are doing, do the FibroScan in probably 3 to 5 minutes, go over the results, all in a 30-minute visit. So that's great. So, that's much easier than the day off you have to take for a liver biopsy or an upper endoscopy. Limitations, there are false positives. It's not available everywhere. The FibroScan itself is ridiculously expensive, so you need enough liver doctors and providers to offset the cost for that clinic to have a FibroScan. So we have something at University of Pennsylvania, there's probably 10 to 15 liver doctors, and we have one FibroScan. I think Indiana, you guys might have more liver doctors and a few more FibroScans, but you're not going to find them everywhere. And that's why the blood tests are really good, because those you can get everywhere. MRI, so the MRI, I'm not going over ultrasound, I think, because FibroScan, ultrasound is slightly better than FibroScan, but not much. It's sort of in between an MRI and a FibroScan. MRI is more time-consuming, but it's more accurate, I would say, of all of the tests that we do for fibrosis. Very low sampling error. It's not influenced by body size or whether someone has ascites, but it is expensive. But there are some liver doctors actually feel that the MRI is a better assessment for scar tissue than a biopsy, because you don't get the sampling error, because you look at the entire liver, as opposed to if we have a needle biopsy, we're only getting 1 out of 30,000 part of your liver there. But claustrophobic inducing, insurance often doesn't cover it, and the cost is comparable to a biopsy, but it's still good. So in patients, I sort of have a tiered system where if I can't get an accurate FibroScan, or if the FibroScan and the blood test that I do sort of don't agree, I'll move to an MRI. All right, so I didn't know you were all getting FibroScans, so hopefully most of you can answer 1 to this first one. And then I guess most people will answer 1 to the FibroScan too, which is good. Craig, will the FibroScan be set up for tomorrow too, for anyone who didn't get it already?
I'm looking at my research team here. I think we'll have it here tomorrow. So again, if there was someone that missed it today and wants to do it tomorrow, we'll make it available.
All right. What's that? Oh, okay, great. I don't know. Craig just told me that people got FibroScans. Could I go over the results with them? But if you have questions afterwards, I'm happy to go over FibroScan results with you too in person, or one-on-one if you have questions about it. Okay, great. The next thing is portal hypertension. Let me see how am I doing on time. All right. Portal hypertension is simply high pressure in the portal venous system. So what's the portal venous system? There's a lot of the blood flow from your abdomen and your intestines before going back to the heart goes through your liver, out your liver, and then back to the heart. And the most common cause of portal hypertension is cirrhosis. So if there's scar tissue in the liver, it's harder for that blood to flow through the liver, and that can cause an increase in that pressure. So we're looking at this right here is the portal vein, and this is the spleen over here. And with portal hypertension, when there's a backup of blood, sometimes the spleen will get a little bit big, and sometimes the platelet count will become low. So what are the tests we have for portal hypertension? So very quickly, we can look and see if the platelet count is low or decreasing with time. That tells me that there's sort of an increase in portal hypertension, or maybe now the presence of portal hypertension. Now, platelet count can be low for a variety of reasons, but one of them is through portal hypertension. And we actually use the platelet count and the FibroScan data to determine whether someone should be screened for varices or not, and what their risk of portal hypertension. So we've actually become very good at using these non-invasive tests to then rule out whether someone needs an upper endoscopy to look for varices. The third thing on here is just something that's very cool. I think it's still in studies. It's called SHAPE, Subharmonic Aided Pressure Estimation. That's why we call it SHAPE. It's a mouthful. But what they can actually do is they can use some contrast with the ultrasound to look at portal hypertension, and it probably has it's very good and accurate. I know they were evaluating this at at University of Pennsylvania, but I don't know that it's out yet to be used regularly, but maybe in 10 years. What about cancer screening? So if a patient with liver disease has cirrhosis, there is a small chance of developing liver cancer. So the two types of liver cancer are hepatocellular carcinoma and cholangiocarcinoma. And then for patients with autoimmune hepatitis, mostly hepatocellular carcinoma is going to be the one that is more likely. But if there's overlap with PBC or PSC, cholangiocarcinoma is possible. Now, the rates are very low, but they're high enough that we recommend screening for patients that have cirrhosis. And how do we do screening? Well, we can use, it's non-invasive. We can use something called an alpha-fetoprotein. It's a blood test that most of the hepatocellular carcinomas will produce. And we can also pair that with a liver ultrasound so we can see if there are lesions in the liver. The best test is actually MRI with and without contrast, but it's much more expensive. So often we'll do screening with ultrasound and AFP first, and if we see an abnormality on that, then we'll move to an MRI. For anyone with metal in their body or claustrophobia, we can actually use a CAT scan. It's faster, but it just has to be protocolized appropriately so that the IV contrast can be given, and we can see all the different phases that go through the liver. So we call that a triple phase. So if this is the lingo that you have to use. If your doctors aren't familiar with this, then you just tell them, I need a CT triple phase if you find something on your ultrasound. And they'll say, what is that? And then you'll teach them something. All right. Function. So this is like the future stuff, but it's still neat. So commonly people will talk about liver enzyme tests as liver function tests, but they're not really. The liver function tests themselves are something, the INR, that's sort of how thin your blood is, and the albumin. So if your blood is thinner, if your INR is elevated, your liver is not producing the factors needed to help your blood clot. And so the INR will go up. The other thing, one of the main proteins that circulates in your blood is called albumin. And as the liver function decreases, the albumin, the serum albumin will decrease. These are just sort of general. There are some proprietary tests that are being evaluated. There's a breath test, and what it does is it takes this isotope of carbon, and it adds it basically to Tylenol, and you drink this solution, and then you breathe. You're hooked up to a machine, and you're just breathing out, and it looks to see how quickly your body will break off this this sort of heavy carbon here. It's fascinating. It's still in development. It's been in development like 20 years. I'm not sure what the problem is, but I think that this test is very neat. It's called the 13C methicillin test, or the MBT, the methicillin breath test. This next one, the HepQuant test, this should be coming out in the next few years. And this uses cholate. Cholate's a substance that our liver makes. And what they did is they took cholate and they labeled it with a heavy hydrogen on one part and a heavy carbon. And what we can do is you drink this solution, and then they take your blood at two different time points, and they see how your body processes that cholate, and it can tell us how our liver's functioning and whether there's any shunting going on. So the HepQuant will probably be available in the next few years. They're working through getting FDA approval. All right, so that was a whirlwind of non-invasive tests for autoimmune hepatitis. I'm happy to take any questions.
So Ethan, real quick, we'll get the questions. Just one consideration. So you did this non-invasive talk. I get this asked almost every month in liver clinic. As a society, as a community, as AIH patients, are we moving to non-invasive? And is that the 5, 10, 15, 20-year plan? What things do we need to get there?
I mean, I'm there now. I rarely do liver biopsies for surveillance. Now, liver biopsies for diagnosis are a different purpose because, and I think, Craig, you and I debate this a lot because I think you're more progressive on this than me, but I feel that I don't think I haven't committed someone to immunosuppression yet without doing a liver biopsy. So, I mean, I think about it, but I feel like at the initial time, I'll usually do a liver biopsy. Now, I think you don't necessarily, if everything is convincing, you don't need to have a liver biopsy initially. But after that, I very rarely do a liver biopsy because once I have that tissue, I know, okay, here's the diagnosis, I know what we're working with, and then the non-invasive tests are almost always good enough for me to determine whether I need to change immunosuppression. There are a few, really there's one case, one instance where it's actually harder is when if someone has steatotic liver disease and autoimmune hepatitis together, it can be challenging to determine whether I need to increase immunosuppression or focus more on sort of fatty liver disease therapies. I think in the past 5 years, I've done 2 surveillance biopsies just to determine which one was pushing it one way or the other. But in general, you can use the liver enzymes, weight gain, and the IgG to make that assessment. But there was one where I had a trouble with that. Did that answer your question? That's good. All right.
Hi there. I guess I have a question. When I was first diagnosed, I had a FibroScan, and it was 25, and it was the day I went in for my first appointment. I was quite yellow. And I just had another one, and it was 5.9. So I have 4 out of 4 fibrosis. I think that's the expression. So how can I be at 5.9 now? Because it almost sounds like I don't have any cirrhosis, but I truly do because I've also had a biopsy.
So that depends. It's like stump the expert right now. So that's why I actually wouldn't recommend the FibroScan at the initial time. It's usually more after therapy's been started, and it's usually good for following because in that phase when you're diagnosed, there's a lot more inflammation, and that can drive the liver stiffness up. Now, it's possible you can have cirrhosis with a liver stiffness of 6. And you'd say, well, didn't I just tell you that that wasn't the case? There are error bars on it. But I will say, if you do have cirrhosis and your liver stiffness is a 6, long-term wise, that will behave very well. So that would mean you wouldn't be at risk for complications of portal hypertension or symptoms of liver disease that we see, jaundice, encephalopathy, or ascites. But we do know that if by treating, really getting good control of the inflammation and disease activity, we can actually cause fibrosis regression in some cases. And so you may have had that. But if your next thing you tell me is that you had a liver biopsy and your fibrosis, your liver stiffness was a 6 and you still had cirrhosis, then I'd say you're more on that sort of outlier on the bottom.
Just one other piece of thought. Again, this idea, I'm still seeing pathologists miss cirrhosis of extensive collapse. Do you see that at Penn?
Normally they'll write, it's hard. At the time of diagnosis, if you have significant amounts of necrosis, it can be almost impossible to make the diagnosis of cirrhosis then.
So what we're talking about is on the biopsy, when it's done with significant liver cell injury or death, the liver cells actually can kind of collapse and look like bands of fibrosis, and we've seen this confused in diagnosis with cirrhosis. So I also then will echo the sentiment of FibroScan within 6 months of treatment start is essentially useless. Now, I still do it all the time. It gives me a place to start. It makes me pat myself on my back, when you come back a year later and it's back to normal. I say, look what we've done. But besides that, it's probably not a great piece to do, and there's actually a lot of literature that looks at this as well. So maybe time for one more question.
Hi, I'm newly diagnosed within the last month, so I don't have a clue, and today's been great. But my experience has been the traditional doctors have all said I'm normal, and the only way they've diagnosed me is through an ASMA, and they said it's showing that I have the AIH. So when I went to them and I read about the FibroScan, they said, that's no good, it's not accurate. You must have a liver biopsy. And I find that's intrusive. I'm afraid of it. How would you handle that? I mean, how can you sound very knowledgeable about AIH. Most doctors are not like that. So I'm thinking of going to an idiopathic doctor. Would that help? That they would be more open, because the traditional doctors are not. And if your scores come back, your blood tests, and you're normal, that's it. They don't want to hear anything else, and they're not open to alternatives. So what would your advice be? Is there a way to look for doctors that are open more than the traditional?
I think the AIHA has a list of is it trusted providers. Is that what it's called? I'm not sure. Patient preferred. Thank you. Patient preferred. Does that still exist? All right. So it is even amongst, I would say, community gastroenterologists will have very few patients with autoimmune hepatitis. So it's good to see if you have a hepatologist in your area, I would say go to that person because they're going to have more experience with the disease. And if you are near an academic center, they'll probably have even more experience, particularly if they're a transplant center, not that you would need a transplant, but it just tells you that there's more and more experience dealing with rare liver diseases and different approaches. So I had one of my patients who I've had for years who trusts me. She, for years, didn't want to go on immunosuppression, and I said, okay. But rather than try to say, you really need to be on immunosuppression, she said she wanted to try everything she could. And then a few years after she was my patient, she came in, she was jaundiced, and I said, I think we need to use immunosuppression now, and she said, okay. So it's important that you're working with someone that you trust also. I hope that doesn't happen to you, but about the jaundice part. But I'm just saying, like, you need to find a doctor that you trust that you can feel confident about, how you want to be treated, invasive procedures, non-invasive procedures, okay? All right, thanks, everyone.
Thank you, Dr. Weinberg. It was great to have you today.